It's coming. What's going on, everybody? Welcome to another episode of the Core Consult RX podcast. And we are... Oh, yeah, by the way, guys, we're live on YouTube, LinkedIn, Facebook, and Twitter for all the students in the room. Yeah,
Wonderful.
Yeah. They were asking me if anyone was going to listen, so I was like, I figured we might as well go live, too. Make it even more... yeah, you're welcome.
That's good.
So we're going to do episode 184 today. And today we're going to do another patient case. So hopefully you guys aren't sick of these. We've done a couple of them somewhat recently, but this one has a few different kind of nuances to it that I don't think we've really talked much about. I know one thing in particular we haven't talked at all.
Since I had never heard of it, I'm sure we haven't talked about it.
Cole has not heard about it, and he was starting to diagnose himself with it, but I don't think he's got it. So we're going to talk about that, and we'll go through the case. We're also going to post like a PDF version with the pertinent information on a like a PDF file that will be on the website. I'll put a link to that. So when I go to actually, once this episode's available on Spotify and all that good stuff, you can get the labs and everything if you want to take a look at it yourself. There's also some like questions, clinical questions, if you will. They're pretty straightforward and easy, but if you want to quiz yourself, go ahead and hit pause, and you can do it. It's a new thing we're trying. It's really cool.
Yeah. But you do a pre-listen quiz and then a post-listen quiz and see what you learn.
Post-listen quiz.
They're gonna like get all of them wrong at the beginning, and then, or maybe they'll get them right at the beginning and then get them wrong at the end.
After they listen to us, they get totally confused. Yeah, probably. Yeah. So we got 3 students in the studio today, and then also AJ is not here, so I'm actually in the AJ cam. So that's good news. So AJ is on a cruise, and he's been gone for like 17 weeks, I feel like. But so hopefully he'll be back with us next time. How's everything going for the month, you guys? Since all 3 are on my rotation, everyone's having a blast, right?
We're living it up.
Yeah.
So fun.
Good. Okay. Well, Austin, that does not sound very enthusiastic.
3 weeks left.
Austin, way to hurt every one of my feelings. That's fine.
Well, it's been my favorite rotation so far. So
that's good.
Yeah.
It's first.
And it'll probably always be your favorite first rotation. So
thank you, Cole. It's still Cole's favorite.
Still my favorite first one.
Yeah. There you go. All right, so let's give some background information first, and then we'll split up the different disease states that we're going to kind of discuss. But BR is a 34-year-old African-American female with a past medical history significant for type 2 diabetes, insomnia, hypertension, dyslipidemia, and newly diagnosed intermittent explosive disorder, for which she is not currently medicated. She had a stent placed in February 2021 during an emergency procedure, had a PCI, after experiencing pain and tightness in her chest, as well as lightheadedness and trouble breathing, and ended up being diagnosed with a STEMI. She came to clinic today to discuss her new psych diagnosis, excessive dizziness and fatigue during the day. It thinks this is due to hyperglycemia. Also the insomnia that she's experiencing at night, as well as kind of a craving for ice. She says she just loves getting crushed ice and chewing it. So, what could that be about, guys? Wink, wink. Drug allergies include lisinopril. It's not technically an allergy, but we have it listed in there because she had a really bad, dry, hacky, ACE cough. Her blood pressure today is 144/86. Heart rate was 84 beats per minute. Her BMI is 30.7. Her A1C in June of 2021 was at 6.4%. October went up to 7.4, and then in April 2022, it jumped up to 12.8, and then in May 2022, 12.5. Glucose today, just a random glucose check, was 240. Her eGFR is greater than 60 mils per minute. All of her other labs are within normal limits, with the exception of her iron labs. Ferritin in particular is quite low. It's a 12. Her hemoglobin is a 12. And her LDL is sitting at a 95 currently. Triglycerides are 82 milligrams per deciliter. Current meds include diabetes. For diabetes, she's doing Trulicity 3 milligrams. She started this back in January, and metformin 1,000 milligram BID, doing the immediate release version. For dyslipidemia and post-stent, dual antiplatelet therapy. She is on aspirin 81 milligrams, clopidogrel 75 milligrams. I'm still taking both of those, and atenolol 25 milligrams twice a day for hypertension. Is not aware of any like statin use. We can't find anything in the record about a statin. So there you go. There's the patient. So where do y'all want to start?
We're going to start with her diabetes.
Let's do it, Austin.
So she started off being a really good patient as far as compliance and everything, and adhering to a good diet. Like her A1C back in June of 21 was the 6.4, and now it's sitting at a 12.5. Coming to find out, she had some nice education from Facebook about the healthy factor of how not healthy diet soda is. So she thought that diet soda was just as bad as regular soda. So she adhered to guzzling 2 to 3 Pepsis a day. So we followed that up with some education on trying the zero sodas, and that was Facebook knowledge that her diet and zeros were not just as bad as regular. Yeah.
Was she taking the metformin, or was she actually being adherent to that?
She claimed that she was being adherent to the metformin. It was the regular release, so not the extended release, and her Trulicity. She did complain of like some ongoing nausea and everything upon eating. So she said that the regular Pepsis were helping her, hence why she would bump that up from 1 to 2, 2 to 3.
I mean, Pepsi's helped me. Or maybe Cokes.
It helps everybody.
But you drink Coke Zero, though.
I do.
She was like, I'm not about that Coke Zero
Well,
life.
you know, I mean, I suffer through Coke Zeros.
You don't like the taste of them?
They're whatever, but like if I can have an actual Coke, much better.
I'm really down with the Dr. Pepper Zero.
I mean, it's fine, whatever, but nothing beats the real thing, man.
I don't know.
Just can't beat it.
I feel like it's pretty good. I was actually really impressed. But the other thing too is and we'll just kind of mention this because we had given her a short course of Zofran when we bumped up the Trulicity dose because she was having kind of nausea, not actual vomiting, but some nausea and stomach discomfort every time we kind of went up on the Trulicity. So we had given Zofran. The second prescription that she was given for Zofran, the pharmacy actually did not want to fill it because they were saying that it could cause QT prolongation, and they were just kind of refusing to fill that until they could speak to someone at the clinic. So yes, that is definitely something that is listed as a potential side effect of ondansetron. However, it's typically something we think about in regards to the IV formulation, and the study in case report and whatnot that have kind of talked about that QT prolongation. It's more so again dealing with the IV formulation, but also if you look at the actual prolonged time, it's not that significant, I think 20 milliseconds maybe.
Yeah.
So it's not anything too crazy to where we'd have to completely avoid the Zofran. If we can keep her on the medication, I would definitely not kept her from getting the Zofran.
Right. Not only that, the Zofran aside, even if it was pretty much any medication that causes QT prolongation, if they're only on one, from a dispensing pharmacist perspective, I generally wouldn't think I'm going to hold that up. If they're on 2 and you're really concerned and you just want to get make sure the provider is aware that there is that interaction, so that they're following up, or maybe you're aware that they have some cardiac issue where you have extra concern, whatever. But one with no other offending agents.
Yeah, not going to be worried about that.
Give her the Zofran. Now she's going to drink Pepsi to make her stomach feel better.
Right. Yeah, exactly. Now my whole problem is off the rails because didn't want to dispense Zofran. Yeah. Come on, work with me, people.
So she's on metformin immediate release, not extended release.
Yeah, but instead she's taking it. I do think we actually got I don't know if we actually followed up with the pharmacy to check her refill logs, but that would be something we need to look into more as well.
So she was on Lantus, but no longer, huh?
Yeah,
so I'm just interested in this bump in the A1C. I get that it probably has to do with the sodas, but was there Lantus involved with the earlier A1Cs, do you think, in any way?
So it was kind of confusing. It looks like the Trulicity was started and then the Lantus was brought off because she was having lows with the Lantus periodically because her diet kind of is all over the place as far as when she's eating and what she's actually, how many carbs she's having per meal. But I think it also, if you actually like start to look at the dates and whatnot, the zero soda,
seems to be the deal.
Yeah, it seems to be where she got away from that zero soda, went to the regular soda around the same time, which I do in a lot of cases. Trulicity can be better than the basal insulin, as far as those postprandial spikes, obviously, especially. But when you're drinking liquid sugar, and whether it's soda, juice, tea, lemonade, whatever, milk, that is definitely going to usually overcome the
if you're
the
guzzling
power of
milk.
Trulicity.
There's something going on there.
Right.
So did I tell you? I told you about that, right? One of my patients who
yeah.
talked about it extensively
Yeah.
about drinks. Nope, nothing. And like, wait, does milk have sugar in it? It was like drinking a gallon of milk a day.
At least, wait, a gallon? It was a gallon?
It was a gallon. At least that's what he said. He said he was drinking 6 gallons a week. Out of 7 days, he would drink 6 gallons.
Like, milk's not like the cheapest drink. You know what I'm saying?
I haven't drank a gallon of milk in the last 30 years.
I mean, that's got to be $18 a week. We're working up to $75 a month on
Hang on.
milk.
Let me check the math. I have no idea what milk costs because milk's disgusting.
So whatever the opposite of lactose intolerant is.
Yeah, he's definitely not that.
Ultra metabolizer.
He's ultra rapid metabolizer,
Ultra rapid
of
metabolizer of
lactose.
lactose.
That's cool. We just discovered a new polymorphism.
We must have from that guy.
Yeah.
But at least milk is a little counterintuitive. The sugared sodas.
Yeah.
Good education. So what's the plan? So we got her up at 12.8. So what is the sodas the plan?
So basically, she's kind of resistant to other medication at this time. So talked about the sodas. She's going to cut them out, and we told her to give her 4 weeks to start at least moving it in the right direction. Go from there. Austin, did you guys talk about potential options for?
Yeah, the Crystal Light was a big option that appealed to her. She really was willing to try the zero since we assured her that it tasted really similar to the regular. And her diet really wasn't a factor because she actually enjoyed green leafy vegetables, which was a shock. So
Diet Pepsi versus regular Pepsi. I don't know. I might beg to differ a little bit. But.
So I will say the Crystal Light I'm a big fan of, but also one of the things I'll even do sometimes is I'll tell patients this, because you'll have patients that want some kind of a ice cream or popsicles or something like that like that, especially in the summer when they want something cold and sweet. Mm-hmm. I'll actually make a really really sweet version of the drink and then freeze it in those popsicle holders and have them do that when they get home from work or whatever, and they have that sweet craving, and that seems to kind of scratch that itch without, it's just basically eating ice. They're not, and she's liking ice a lot. So
yeah, which we'll talk about. Yeah, they do actually. They have 0-calorie popsicles that they market, but they do still have some sugar in them. I don't fully understand how that works.
So
but
they basically can get away with saying no added because it's essentially no added sugar.
Right.
So there's actually the Reese's candy, and like there's a Reese's and a Hershey's version. It says in huge bold letters across it, sugar free. And then you flip it over, it's like 3 pieces of candy is 16 grams of carbs. Right. So like, we don't know what free means. So yeah, it's very frustrating.
Yeah, but good to know. You got to look at those labels.
Yeah, for sure.
Okay.
So all right, what's next, Miss Kaylee?
Yeah, so I'm going to talk about the psych.
Talk loud, Kaylee. We want to hear you.
Okay, is this better?
Mm-hmm.
I'm going to talk about the
Fantastic.
intermittent explosive disorder. This was interesting to me because I'd personally never heard of it either. This is not something we covered in DPT, but it's described as flying into rage for no reason. They have behavioral outbursts that are out of proportion to the situation. It's actually characterized under an impulse control disorder, and it's marked by problems controlling emotions and behavior that will result in behaviors that violate the social norms. So some potential causes could be a genetic component, being exposed to verbal or physical abuse in childhood, and then just a history of other mental health disorders like ADHD or antisocial disorder, or even borderline personality disorder. And they do know that most patients with this disorder have a lifetime history of other psych disorders, including like alcohol abuse, social anxiety disorder, and phobias. Some signs and symptoms are just irritability, rage, increased energy, racing thoughts, poor communication, inefficient information processing, tremor, palpitation, stuff like that. The outbursts typically last less than 30 minutes, and the patient may feel a sense of relief after their outburst. And the initial outburst would typically occur in response to something provoking, but it could also occur spontaneously. Some examples of outbursts that we found were like physically striking people or animals, verbal outbursts, threats, and physical aggression to objects such as like throwing plates and slamming doors. You diagnose this disorder using the DSM-5, and the goal of treatment is remission, which is defined as resolution of symptoms or improvement to the point that only 1 or 2 symptoms is considered mild. The patient should also be advised to avoid intoxication with alcohol or other substances because those significantly increase the risk of violent behavior in these psych conditions. So with all of that being said, the treatment of choice is fluoxetine 20 milligrams once daily, and you can titrate up to 60 as needed. There was a trial in patients with this disorder that said fluoxetine does have a clear anti-aggressive effect in this disorder. Some typical side effects we do see with this drug include sexual dysfunction, sleep disturbances, nausea, vomiting, and restlessness. And I do think this patient experienced some insomnia due to the antidepressant. So we'll go into what we can do with that in a second.
Cool.
Interesting.
Yeah.
So, did you run into this before, Mike?
So I saw one patient when I was seeing when I was kind of doing consults with Dr. Santos, doing psych consults. We had a patient who basically had a lot of the symptoms of this. So I had read about this in an article from that psychopharmacologyinstitute.com, like the continuing ed group that they read all those algorithms and whatnot. And if you haven't checked that out, if you like psych pharmacotherapy, I definitely encourage you to check out their website. It's good. But basically, I had heard of this on that website, and then when I was listening to the patient kind of explain like a lot of the symptoms, it fit a lot of these kind of this sort of narrative. And so she had been on sertraline, and it was not because technically speaking, you can use any SSRI, but she had been on sertraline. I think it was 100 to 150 milligrams a day, and was still having these outbursts like in traffic and like at work, and was like getting threatened to like lose her job and things like that. So we switched to fluoxetine, and within a month, she said the symptoms were like almost gone.
Great.
Yeah. So it was kind of cool to actually see it play out in real practice.
I was interested in how common this was, and I came across a couple numbers that range anywhere from like 1 to 7% of like general population, which seemed like a lot. But there was a caveat that the DSM criteria for diagnosis changed between the DSM-4 and the DSM-5. And the DSM-4, it used to be that it could be a planned situation, but now they specify now in the DSM-5 that it has to be impulsive, which I guess that would decrease the amount of people possibly that would experience this. Is it like a couple of instances of this and you're diagnosed with this, or is it like a temporary thing that can resolve? Do you know?
I have to pull it up again. There's from what I remember, there's a like a time period. There's a few different it has to be like a certain number of times, like in a 3 to 6 month period.
Right.
I have
so
to
it's
pull
over
up the
time.
exact-
It's not
yeah,
like
yeah.
a single instance.
No. Because I think all of us have gotten quite mad in traffic
Well,
at one point.
I was just thinking, it just described feeling better after the situation, and I'm
Man,
like,
that was I'm glad I yelled at
Yeah.
that person or started hitting animals.
definitely punched a couple of walls or something when I was in high school playing sports, and it definitely felt better afterwards. So.
I don't think I could picture you punching
Ah,
walls. I really
Yeah.
don't. I feel like you'd be like, never mind, I'm over it.
buddy of mine did that and broke his hand.
Oh, I had a friend of mine in pharmacy school that did that.
Yeah.
And they're like, good punch.
It's like during basketball season, and
Punched a dumpster. I was like, man, what'd you think was going to happen with that? Shattered his hand.
Fun fact,
Yeah.
this is actually super embarrassing, but I kind of did the same thing. I punched a wall, and
Heck
it
yeah.
was so stupid. Like, I'm not that type of person at all, but I was
Wow.
like, I don't know, maybe like you said, it'll like make me feel better. So I hit a wall, and then I did break like my pinky knuckle.
Yeah.
Because I also don't know how to punch, obviously, if I
Well,
punch with my pinky first. So
I
That's
generally
not ideal.
punched. I didn't do it often, but I generally punched soft things. But I did like. I remember I was having an argument with my brother. Oh, well, I've got a couple stories now that I think about it. But I was having an argument with my brother, and I really was not very angry, and I pretty lightly hit the wall and just like busted through the drywall, and I was like, oh my goodness, my dad's gonna kill me.
You go, man, I'm tough.
Yeah. There was another situation
Very
where I very lightly, I swear it was light, punched the his Jeep's what is it called? The front window, whatever it is.
The windshield?
Windshield. I couldn't think of the word. Just like spiderweb,
Really?
like shattered it. Yeah.
Turns out Cole's a great puncher.
I don't know.
That's good.
I don't know.
That's good. Yeah. Emily, you said you're not that kind of person, but I feel like there's evidence to the contrary since you did in fact break your hand. Also, if you guys noticed from the video version, Emily doesn't have headphones on. Everyone laughed. Yeah. That's because she can't be trusted not to throw me and stuff. So we had to take her headphones away.
that's not why.
Yeah,
That's not why.
that's definitely why. All right. So, we mentioned fluoxetine, but Kayla, you were talking about the insomnia being a potential option, or a potential problem, I should say, not option.
Because she already has underlying insomnia,
Yeah.
right?
And so, starting on the fluoxetine, I will say, yes, fluoxetine is listed as potentially causing insomnia in some patients, but I also have seen a lot of patients that do just fine with it and don't have that aspect. But she's already got the underlying insomnia. So at that point, we're going to have to figure, what we can, which medication route we can go other than, sleep hygiene and all that. So there's our trazodone option, like we've talked about in the past for certain instances. But the orthostatic hypotension is definitely a risk. And also it's one of those drugs that, it can help a little bit, but it's not all that effective. And it usually has sort of a plateau effect that doesn't end up, kind of working long term for a lot of patients, but it is not a controlled substance. So that's one thing to consider. Do we know if it's sleep onset insomnia that she's dealing with, or if it's like sleep maintenance? Like if she has trouble staying asleep?
I think we made that part up. So
Did we?
whichever one you want.
Doggone it. Okay, well, we'll say okay. You know what, Emily, that's it. You're grounded. So in the case of like isolated sleep onset, if it's truly like sleep onset, there's a few different options. If there's the zolpidem is one that a lot of people do end up going with. But because of her history of psych disorders and things like that, if we wanted to stay away from a benzodiazepine or a hypnotic, there's there's the trazodone. There's also Relmeton, which that one's pretty hit or miss as far as the way the data looks. Low dose amitriptyline is another one, but we do have to worry about the anticholinergic effects of that one. The orthostatic hypotension is still a factor with that, as well as potentially even some QT prolongation. We all know that she has an issue with getting meds that can cause some QT prolongation.
No, I appreciate the pharmacist being
I do too.
being cautious at least. Yes.
Yeah, thank you, Cole. You're always very positive. And then also mirtazapine. So, but the problem is this patient does have a BMI of over 30, and mirtazapine can definitely increase appetite pretty extensively. So I would be a little bit worried about that one. However, if we were going to use mirtazapine, I will say that we would have to stick with low dose mirtazapine, because that's the one that actually induces fatigue and has more binding affinity for the histamine receptor versus the higher doses that we would use for like true like depression or something. When you get to the doses 30 and 45 milligrams, you start getting more affinity for other receptor types and not so much the histamine receptor. So you start losing. A lot of times patients will have fatigue initially, and then their bodies get used to it, and the fatigue is not as prevalent as the higher doses. So that's something to encourage. If you are going to start make sure you keep it at the low dose and don't titrate up.
Hypothetically, if we hadn't done fluoxetine and just know that she had a good response to it, could Remeron have been an option for the sleep and the explosive disorder, or probably not, since the SSRIs are indicated first line?
Yeah.
Explosive, probably not.
I'm not sure. Yeah, I don't know. I'd have to look and see if there's any data with mirtazapine. I actually don't know.
I doubt there is. I was just wondering.
If it's sleep maintenance, though, there's a couple different things we could look at. There's one that I tend to like a lot. Shout out to Patrick Key for kind of putting me onto this one, but doxepin is one of those tricyclics that we don't really think about too often. But the low dose doxepin can be very useful for sleep maintenance or mixed insomnia, and it's not a controlled substance, and so you don't have to worry about them being on benzo or hypnotic or anything. It does have some things to watch out for as far as the like side effects and whatnot. I mean, anything that's a tricyclic, you're going to have some kind of anticholinergic side effects, and same with like QT prolongation and all that. But it's usually a lot less, more like a lot less pronounced than some of the others like amitriptyline. But you're going to definitely see patients that will utilize that because we're trying to stay away from some of those more controlled substances. And, there's several other options. There's actually, have you guys ever seen the Sonata? It's like the really short acting.
Zolpidem.
Yeah, Zolpidem. So I've actually seen some cases where the patient will, because it's got like a half-life of an hour, patients will wake up in the middle, as long as they have, the 3 or 4 hours left in the night, they can take one of those and it'll be out of their system without the residual effects in the morning. So I have seen that as well. So it kind of depends on what the situation is. Obviously, too, you have to think about the serotonin levels. Doxepin at the low doses, we're dealing more so with other, like the histamine receptors and other receptor binding affinity than we are with serotonin, but that's still going to come up as an interaction and something to at least be aware of. If you want to double check doxepin's, all of their kind of clinical teaching or counseling, you can check out your Pearls app. Right? See, I throw that right in there. Just making money. So our sponsor today, our daily Pearl, if you will, is doxepin. We'll do that. So counseling points, we've already mentioned some of them, but just make sure that you note to patients that it could take about 2 weeks to start seeing some benefit, 4 to 8 weeks to see a full effect when you're treating depression. It will cause some drowsiness, so even if you're not using it for insomnia, make sure they still dose it at bedtime, ideally, and then those anticholinergic effects, including the constipation, blurred vision. It can also cause some vivid dreams, potentially. It also can cause a little bit of decreased libido, so make sure patients are aware of that. So if you have not checked out Pearls, pyrls.com/coreconsultrx, get your free download and your some solid charts, and put out a new community-acquired pneumonia algorithm, all kinds of good stuff on there. So make sure you check it out. Thanks to Pearls for looking out for us. What do you guys want to talk about next? I plugged.
So, going back to the other options for the intermittent explosive disorder, so resistant disease would be defined as the patient is not responding to the SSRI within 6 to 12 weeks of starting therapy. And this is interesting what drugs would be what we would go to next. It's mostly what we think of as seizure medications like phenytoin, carbamazepine, even like Lamictal and Topamax and valproate. So that's kind of interesting.
Yeah, because they can all be used as mood stabilizers, and I guess that would be kind of the goal there.
Do you have one you go with, Kaylee? Any of them you like more than others? Just out of curiosity. There's no right answer. I'm just asking.
I feel like I do Lamictal the most, so let's go with that one.
Cool. All right. There you
Why
go.
not?
We'll have that in our back pocket. All right, y'all. What else?
You want to jump into her hypertension?
I'll allow it.
All right. So she was on atenolol, 25 milligrams twice a day until we got a hold of her. And we're changing that today because it was like multiple trials, right? That patients with hypertension, atenolol showed to be like no better than placebo, and if anything, like worse than placebo.
I don't know. You're telling
Is
us.
that what you're telling us?
Is that what you're? Oh, is
That's
that
what you were telling us the other day, I
was
think. But
teaching you. Okay, cool.
yeah, when it comes to reducing all-cause mortality and CV events, it's inferior for sure. And
for sure,
it may even increase stroke or like even death risk compared to other antihypertensive drugs. So not our fave.
Not ideal. So what Emily is referring to is a meta-analysis from Lancet, I think 2004, that was initially looking at atenolol versus placebo, and then they looked at atenolol versus other antihypertensives. And with in regards to all-cause mortality, cardiovascular mortality, MI, and stroke, there was no difference between outcomes when it comes to atenolol and placebo. And then atenolol versus other antihypertensives, atenolol tended to be worse for all-cause mortality and cardiovascular mortality. With all-cause mortality, there's a number needed to harm of 111.
111.
Yep.
Wow.
So atenolol is not ideal.
It's not ideal. Regardless, any beta blocker, I mean, I'm looking at her history, and I see she had a stent, but she didn't have an MI. So I don't really see an indication.
I had a STEMI. So
she did?
Yeah.
Oh, okay. So
that's why. But the wrong beta blocker.
Okay, yes.
I still don't like it. So yes, I will point out that the meta-analysis was was looking at patients with primary hypertension, but because she has hypertension as well as still maybe needing she also had the MI back in February 2021. So how long are we going to keep her on the beta blocker? So I've seen some data around 1 year, some people saying 3 years. So it kind of just depends on what we end up coming up with. But the carvedilol, labetalol, or nebivolol would be the ones that would give the most actual blood pressure lowering, as well as providing the beta blockade. Because you get the alpha beta blockade with carvedilol and labetalol, so you're blocking not only cardiac output, or lowering not only cardiac output, but also you're lowering systemic vascular resistance. And then with nebivolol, Emily, we can hear you. How dare you? Everyone look at Emily, and she's wearing a NASA shirt.
Well, then I'll just ask out loud, since we kind of made this person up, are we not saying that she has primary hypertension? We're just saying that she was on the beta blocker because of her episode?
Well, what's her blood pressure?
I mean, it needs it.
And also, we didn't make this person. This is a combination of two people. What are you talking about?
Well,
this is a patient we literally saw yesterday. Half of them.
Half, yeah.
Okay, Emily's not invited back, everyone. Everyone say bye to Emily in her no headphones and NASA shirt. Where's TJ at when we need him? Shout out to TJ. TJ's Emily's husband, by the way. I'm that way. That's it. That's going on TikTok.
Okay. Well, I'm going to say that she has primary hypertension because she does. But so because of her cough allergy to the ACE inhibitor, we decided we would try losartan 50 milligrams, and we wanted to do that in the evening because of the Hygeia and MAPEC trials. They talked about the significantly lower blood pressure and rates of CV events in patients that took at least one of their antihypertensive drugs in the evening as opposed to in the morning or just sometime during the day. Yeah. And then interesting info about losartan and ARBs in general that I learned in PA school this morning. So tell me if I get this wrong, because I just learned this in your lecture this morning. I learned the details of it. But so you don't have to worry as much about the angioedema or cough with ARBs because they work in a different part of the pathway. So it allows for the breakdown of bradykinin, so which doesn't happen with ACEs. So they get a buildup of bradykinin, and that's what causes the acute airway angioedema. Is that right?
Mm-hmm. So basically, because an ACE inhibitor is blocking the conversion of angiotensin 1 to angiotensin 2, and also an ACE inhibitor, or ACE, the actual enzyme, is responsible for the breakdown of bradykinin and other things as well. But because an ARB is blocking the actual receptor, it's further down that RAS system, and so you're still getting that breakdown of bradykinin from ACE, that enzyme itself. And so we would typically not think of it as causing a cough, or there's some debate around this, but it would in theory not cause angioedema either. And in fact, the heart failure guidelines and say that if a patient's had angioedema on an ACE, to give an ARB. Definitely a good option.
Less of a concern. So in her, we're thinking she needs a beta blocker because she's post-MI. So we got the beta blocker on board.
Were we saying we were going to ditch that because it's been a year? Or
did you say it's been a year?
Well, I think it was February, so it's been over a year.
So we can ditch that.
We do ditch that. then we can just, so the other, losartan is definitely an option. I will point out the Valiant trial, looked at valsartan post MI and showed that it can be, so if we wanted to go something evidence-based, I'm sure there's some data with losartan as well, but just to throw another option out there. And that was, just a potential alternative if she just didn't like losartan for whatever reason.
It kind of has a shorter half-life, right?
Valsartan?
No losartan. But valsartan's twice a day, but doesn't losartan have a bit of a less than 24-hour-ish kind of half-life?
Yeah, you can dose it. We dose it 12 out every 12 hours at my clinic.
Yeah.
Yeah. And then she's also on clopidogrel and aspirin still, which is kind of weird.
Yeah.
So, really, if even post-stent, like the dual antiplatelet therapy, can be utilized for that first 12 months. But after, PCI, and we typically don't think of, needing the dual antiplatelet, or at least we're reassessing to see if she still needs it.
Right.
I basically our plan was to have her follow up with cardiology because she hadn't been in a while.
And it's at least controversial. So there's the DAPT trial.
Yeah.
A couple others, and it's kind of a risk-benefit-ish versus bleeding sort of thing. But yeah, it seems like after a year, unneeded unless there's other compelling indications. And
the other thing is, that was kind of interesting too, is they went with clopidogrel, where she has diabetes and she has other risk factors. The Plato trial looked at ticagrelor versus clopidogrel. Both patient arms had aspirin as well, and the ticagrelor did do better in patients that had other risk factors and whatnot. And so I believe the number needed to treat was like 50, 54, somewhere around there for the primary outcome. So it was a little bit better, but it did have a slightly higher bleed risk. And if you went above 100 milligrams of aspirin, so it needs to be the 81 milligram aspirin in the U.S. anyway, then because if you went above that, the bleed risk outweighed the benefit at that point. But this patient could have probably been a candidate for ticagrelor over clopidogrel, but I don't know if it was just a cost thing or what the issue was. But just throwing that out there to kind of keep in mind.
So you mentioned post-MI has a stent, and you didn't see any history of a statin, right?
Right.
So that's kind of important.
Kind of important.
Only slightly.
But what's interesting is her LDL is only 94.
Which is actually pretty solid for no statin and her diabetes.
95, excuse me. Yeah.
Yeah.
But being said.
Yes, she'd be indicated pretty clearly for a high-intensity statin.
Yeah. And that, you can look at like the TNT trial. There's various studies that have seen preventing secondary ASCVD events with high intensity statin. So a TOR of 80 right off the bat if she hasn't been on one. If she's with the myalgias, myopathies, then we can switch to a hydrophilic statin, which is going to have less volume of distribution, less risk of that tissue penetration, and we can go with Rasuva 40. Same thing. Jupiter trial.
Yeah. And so would she be kind of a candidate for a goal of less than 70 for her LDL with the
at least
primary prevention plus diabetes?
Mm-hmm. Yeah, and depending on if we really calculated it up, maybe even
the ultra or whatever it is,
extreme risk.
Extreme. Yeah.
I don't think she quite would meet. Maybe I have to look at it, but that would be the less than 55 according to the ACE guidelines.
Yeah.
So I think she'll definitely be less than 70 for sure, though, with a high intensity statin.
Yeah. Oh, yeah. She should get a 50% reduction if she's not been on anything.
Yeah.
I kept thinking about her Trulicity. So we just had a new kind of big approval in the last couple of days, right?
Yeah, we did.
So do you think that once that's available, she'd be a candidate for tirzepatide?
She's got Medicare, so I would assume they're not going to have it right now. But we'll see. I hope so. I hope that they can get it on formulary pretty soon for all kinds of insurance companies.
Yeah.
It'd be great.
It would be.
I also didn't mention the iron levels. So just to throw this out there, because not taking any iron supplementation right now, but historically for irons, kind of replenishment for like a microcytic anemia, iron deficiency anemia, they've used 100 to 200 milligrams of elemental iron per day.
It's quite a bit,
which is nuts and causes tons of constipation and issues. And so there's actually some evidence now. There's multiple studies that have showed that like every other day dosing, or even I've even seen it Monday, Wednesday, Friday dosing of one ferrous sulfate 325 is enough to replenish iron stores, because you almost get like this paradoxical effect where if you take too much of it in a day, it's not going to actually be absorbed. I feel like the women's health, the OBs, the OBGYNs, the midwives, all of them they're like so up on this, but primary care is like still, no, iron, ferrous sulfate twice a day, every day.
Yeah.
Just deal with the constipation.
No, it's counterintuitive to anything I've heard. I mean, I would say the increase in side effects makes sense, but the decrease in absorption doesn't. But it's a real thing. So in a lot of instances, they are recommending don't even do daily dosing. Just do every other day. And they've seen better, equivalent or better iron absorption in those instances.
Yep. Good deal. Anything else with this patient?
I don't think so.
You sure, Emily?
I'm sure. I think. I don't know.
Going to get them all fixed up. This is good. We didn't even have to like change a whole bunch of things. A lot of times when we work these patients up, we're like, yeah, you know, you would do all this today. You would do this, blah, blah, blah. But I mean, most of the things we said are pretty reasonable to do.
And I think a lot of it's just more so diet, education, lifestyle
Yeah.
stuff. Yeah. Pretty doable.
Yeah.
They'll follow up with them this week. The 2 patients that we used, since Emily called us out on combining patients, told
I
our
mean, we
secret.
still spiced them up. Like, not all of this was from those 2 patients.
Okay, well, Emily, you're really ruining this episode for everybody. She's determined. Look, everyone, see, there's Emily just ruining the case.
I mean, that's what they do for like tests and stuff. So like the people that are using this for like study purposes,
This has
your
to be real.
patients
Everyone,
might not
okay,
always
you
be
know what?
real. I'm
That's
sorry.
it.
Like the patients who take
That's
the
it.
test
Just
on.
go ahead and delete the episode. This can't
Okay.
get out. We've ruined it. It's too late for us. Sorry, everyone.
Well, maybe if you actually edited these,
No, I
you could
can't.
fix
I
it.
don't have time for that.
Oh, yeah. You could just edit out that she said that, but
Just
no.
make it blank.
Yeah. Just
Something happened.
Yeah. Emily starts talking and then it just like beep because it's redacted. We redacted the episode.
Yeah, it just says redacted. If we're just going to be a 3-second thing of us just going, we're sorry, we had to take this episode. There's too much vulgarity from our students.
I think we'll have to wait for AJ to get back to do that, right?
I hope maybe.
He's the one.
Maybe, yeah.
If he ever comes back.
Or is
Yeah,
AJ
he might just be a permanent cruise guy. Yeah, we'll have to check out. If anybody sees AJ, please return him to us. He's missing.
He's on a missing child.
He's been gone for like 2 weeks at this
I
cruise.
saw his face on the milk carton today.
Yeah. I put it there.
I have a carton of milk in my fridge.
Do you?
Yeah, I don't use those plastic jugs. I use cartons.
Yeah, well.
No, I don't.
I was going to say, do they make those anymore?
not unless you're in middle school.
Was this 1983? Oh, geez. Okay, now we've lost everyone. So thank you guys so much for listening. I hope that was somewhat helpful. Definitely check out the actual case itself. We'd love to hear your thoughts, comments. If you would do anything differently or completely disagree with our recommendations, we'll take a look at that, as well. And we want to learn just like you guys. So we'd like to hear your thoughts. If you want to send us an email, you can hit us up on any of the social media platforms. You can also send us a text directly if you want to go that route. The number will be in the show notes, but it's 415-943-6116. Also, make sure you check out www.patreon.com/coreconsultrx. There's going to be lectures, and I'm also doing practice questions up there now for pharmacotherapy practice questions that go along with the lectures. And so hopefully you guys are liking that. I definitely appreciate all of you who have joined and supported us through that. It means a lot. And we will see you guys on the next episode. Bye, everybody.